It's hard to be the last speaker of the day, but hopefully we'll get through it together, and I'll share some of my pearls with you. I'm going to be talking about communicating with children and adolescents with serious illness and their families. I do have a disclosure, and that is that someone who has partnered with me in putting together this talk is someone I'd mentioned previously, Abby Rosenberg, whose work centers on building resilience and a focus in particular on adolescents and young adults, and she shared some of her wonderful slides with me. So what we will accomplish in the next half an hour or so is identify barriers to effective communication, describe strategies to have meaningful conversations with families of seriously ill children and teens, identify communication phrases that have unintended harmful consequences and those that can facilitate easing of suffering, and then strategize specifically about communicating with seriously ill children and their families. So, why is communication so difficult? I'm going to pause and wait for answers and have a sip of my water. So it's participation time. And I'll say that as a palliative care clinician, I can be silent for a very long time. Any thoughts? Yes? Oh. Hard to say what we really mean because we feel like it will be hurtful.
It can be hard for the parents to hear you. You can say it in plain language if they're not ready to hear it somehow.
So hard to absorb. It's both on the perception, reception, sort of the give and take of communication. Denial. As maybe a coping strategy that enables people to carry on and yet may preclude absorbing information. You know, the other thing that I would like to add is that even though almost all of us learn how to communicate, and even those children who are nonverbal communicate sometimes with their eyes and their expressions, and children who are verbal can, rattle off so many things, and it's quite natural to learn how to communicate. There are skills to communication. Communication that is healthcare communication is beyond what we come naturally by, and therefore we have to take notice and to learn and then teach about communication. So speaking of education, 80% of pediatric, this is in the US, hematology, oncology fellows reported that communication training is important. Only 32% received communication training other than direct observation, the see one, do one, teach one strategy, that modeling behavior, doesn't always make explicit what the skills are that we have to learn. And then what about attitudes? So the pediatric oncologist's greatest barrier to difficult conversations, this is adapted from Joanne Hilden's work. Top barrier, families, unrealistic expectation. Families' denial, we heard that. Family conflicts, patients' denial, refusals, legal and ethical issues. So as providers, this is a provider survey, who do we blame for poor communication? The families. And yet it's our responsibility. We hold the responsibility to effectively communicate. And this is what we do when we're not trained to communicate in pediatric care conferences. The provider speaks for 73% of the time. The parents speak for a quarter of the time. And we speak medical talk 79% of the time and ask about family values and preferences 21% of the time. Communication isn't only about actually stating the words, but it's a procedure. It's a give and take, and there are, as I said, skills. Then there's provider barriers to discussing advanced care planning and the typical timing. Again, this is another study, unrealistic parent expectations, differences between clinician and parent understanding, lack of parent willingness or readiness to participate. And yet, as providers, we say that these conversations happen too late. And here's another study being prepared for publications about advanced care planning. That's the definition that was given. 65% of bereaved parents had an advanced care plan, and 18% of those who didn't would have wanted one. And from a parent perspective, the importance of a care team talking to families about the creation of advanced care plan, a majority said very important or important. So families actually want this communication. We don't give it because we think families don't want this communication. So there's a communication challenge there. Again, parental preferences about timing for advanced care planning discussions, not at the time when death is imminent, or not, or sometimes at diagnosis, or after the child has been reevaluated after the serious illness diagnosis, or when the clinician believes that the child will not survive, but not when death is imminent. And it's not the palliative care specialists who should be delivering this kind of communication. Families actually want this is intensive care unit clinicians, or their subspecialty clinicians, or their general pediatricians. And so they don't want to hear it necessarily from palliative care specialists. All right, so we've decided that there are barriers to communication. Then how do you go about communicating with these families of seriously ill children? Well, I say let's start at the very beginning. And when you read, you begin with A, B, C. When building a relationship, you begin with 5 questions. All right? And these are the questions that we teach our fellows and believe that they are magical, in that if you have a conversation that embeds these questions, you can go into a family discussion where you've heard how difficult, hostile, unwilling a family is to have some kind of conversation, and you can leave that encounter by hugging each other. And so that's magic, right? Except that there's also a strategy behind that magic. And the first question is simply, and we heard one of our speakers say, tell us about yourself as a person. What are your qualities, right? Well, in order to care for our children and their families, we need to understand them as people. We don't want to know first and foremost about their illness, their disease. We want to know what makes them happy and what do they enjoy and what brings joy to them. And in so doing, we can get to know the person behind the patient that we're taking care of. And then number 2, we do want to understand where the family's starting from. Tell me about your understanding of your child's illness. Number 2, your understanding of your child's illness. And then we're still not explaining anything. In light of that understanding, what's most important to you? What are you hoping for? Also, what are your worries? And what are your fears? And then the last question, which is so crucially important and a little bit different, is, in times of difficulty, where do you find your strength? And not only where do you find your strength, but how well is that working for you right now? And through that question, we hear a whole host of information about strength from family, strength from community, strength through their beliefs or their religion, and it enables us to really know what to harness to surround that family with sources of strength. And when we finish this conversation, which I call a goals of care discussion, not advanced care planning, this is before advanced care planning. This is when we meet a family, how we come to understand them in the experience. This is a goals of care discussion. And after each question, of course, you pause, so that in this conversation, a majority of the dialogue is happening from the family, and we're listening. And then very importantly, when we're done, we summarize. And the summary is how we start to delineate goals of care, because if you just ask a family, what are your goals? It's not a very tangible question. We are professionals and we have to help articulate those goals, but we can only do it by truly understanding where the family is coming from. So, what is most common at the end of this conversation is that based on our discussion, my understanding is that you are hoping that your child lives as long as possible and as well as possible. And then I ask, is that correct? As long and as well as possible. And you will note that, for the most part, these goals of care fall into one of three categories. Live as long as possible and defer quality of life. For some families, leave no stone unturned at the expense of quality of life is what's most important to them, and we need to embrace that goal. Of course, we need to consider the child's experience as well. Live as long as possible and as well as possible. I would say the vast majority of families hold that goal as what they hope for when they know their child is seriously ill. And we talk about denial, and we talk about the fact that maybe families haven't absorbed the information that we gave them about the fact that their child is likely to die from the illness that their child has. I would say, and I've done many, many interviews of bereaved parents, that you only need to say that once, and that family has heard that. They may not want to express it out loud, but that does not mean that they're in denial in the sense that they don't get it. It's just that it's too painful, and making them say it is almost harmful to them in that experience. But they do want their child to be comfortable. And then towards the very end of life, often we find that the goals are transitioning a little bit to live as comfortably as possible, foregoing disease-directed therapy. And so when we have this framework of three buckets, we know then how to take care of the child, and it's truly how goals of care then direct the care of the child from there. All right, so I want to shift a little bit to specific communication phrases, because as my friend Eric Cassell, who I introduced to you earlier this morning, said, similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words, because any error can be harmful. And families, again, in their bereaved interviews will say, I have never forgotten when the resident, let's talk about the residents who, bless their hearts, haven't been taught well enough, came in and was so frustrated with me and said, don't you know that your daughter is dying? Something so harsh like that. Sometimes our emotions get in the way from how we deliver the message. This is just a cartoon that says, sticks and stones will break my bones, but names will never harm me. And of course, here's the dictionary, harming Garfield. So we know we can be harmful with our words. So here's the next part of audience participation. What are some of the phrases that you have heard or been told create harm in the way in which we use them? Another pause for a drink. Nothing more we can do. Perfect. Thank you. There's always care that we provide. It's not this chemotherapy or nothing, right? No hope. That's right, because families have hope to the very last breath, and so that sends a very devastating message. What else? Withholding care. So, it's like sometimes people say, "Oh, you're being too picky," because we never withhold care. We withhold, or I say discontinue or stop or not start some type of intervention like a ventilator. But people call me picky when I say, "Oh, what's the problem with withholding care?" Because we don't know how it's received. And also, it's not only how we talk to families, but we communicate within ourselves, and we set up a culture of sort of talking differently as clinicians than we do with families, and then those words escape to families. So a family says, my child's a DNR. Well, a child is never a DNR. Or we say to each other, they signed the DNR, and this may be country specific, but in our country, the family doesn't sign the DNR. The doctor or the nurse practitioner signs the DNR. So all that subtlety then creates confusion, barriers to how we might be delivering care. There's so many other phrases, labeling someone by their disease, to say the child failed a treatment, as though that child really had a choice in the matter. The word appropriate, a woman by the name of Mary Ellen MacDonald is an amazing anthropologist in Montreal, and she spent a year in an ICU just observing in her anthropology work. And one day she simply counted the number of times we as clinicians said, "Oh, the family was appropriate," or "the family was inappropriate," and how we use that word to judge all the time. And it sets up again a stereotype or an impression, as opposed to the family was upset, and just naming what happened as opposed to judging what happened. And there's words that we use, like palliative care is up there, and we talked a little bit over the break whether or not you call your service a palliative care service, which we do not. And I don't have strong feelings about it, but we're the Pediatric Advanced Care Team. We're packed in order not to set up an unintended barrier. There's more we can talk about this. I wanted to share with you this eulogy about a beautiful young boy, a teenager named Nate, that his mother wrote. And it's what's highlighted in what's bolded. Often we hear about a child battling cancer as if he's at war with his own body. But this metaphor is unfair. It assumes that the child somehow has control over his disease and plays a role in his own success or failure to cure it. Nate understood the complexity of his situation and chose to focus on making every day count. A few months ago, Nate posted a picture of himself on Instagram and was angered by somebody's comment, "Keep fighting." To the rest of us, it seemed like a perfectly reasonable comment, but Nate said, "Why do people think I spend my time fighting every day? I'm just living like everybody else." All right. Well, if there are phrases that send unintentionally harmful consequences, what phrases facilitate communication? And these I'll share as my communication toolbox phrases, and one of the things that we tell our trainees, because we actually have to break down their language and then retrain them over the course of a year that they're with us, is start to have some toolbox phrases. When you're in a moment of difficulty in a conversation, what can you go to pull out that phrase? So the icebreaker, we talked about tell us about your child as a person. In the NICU, we ask often, tell me how you chose your baby's name. And it's so many beautiful stories come out from just the name of a child. And sometimes it's as simple as, oh, I read it in a magazine and I really liked it. And sometimes you hear the whole family history and how they got to that name. What about responding to emotion? So this is one of the most critical aspects of communication. When someone starts to seem frustrated or angry or sad, sometimes we want to quickly run past that moment because we're uncomfortable ourselves. But are there strategies to respond to that emotion? Sometimes sitting in silence is the best response, giving space for that emotion, and the person will then pick up the conversation. And sometimes it's naming the emotion and saying, I'm so sorry, this is difficult. And sometimes it's by empathizing by saying, or not being able to empathize by saying, I can't imagine how difficult this must be for you. And that, to me, is the phrase that I hold on to when I'm at a loss for words. It just helps me in that moment. Setting the stage for a short visit. The fellows love this one. So how could you be present and still know that you can only be there for a few minutes? And so we teach the fellows to say, I have about 10 minutes when they're beginning a conversation. And 10 minutes can be quite long, especially if you sit down for those 10 minutes. Or when it's getting to the end of time, I'm aware of the time, a wrap-up exit strategy. So what I'm hearing to summarize, and that I'm aware of the time. And then there are just additional phrases that work wonders in, again, forming these relationships by saying, loving parents often decide to do one thing, and equally loving parents decide on another course for their child. Sometimes it's the I wonder statement. This is particularly helpful for the other teams for which you're trying to gently make suggestions, and you instead of having them become defensive around your suggestions, you say, I wonder if it would be helpful for that particular child to consider some morphine. It's an I wonder phrase. And then I wish and I worry. I wish I had better news to tell, but I worry that your child's time is short. I wish and I worry. Again, these are all just strategies. And what if you make a mistake? You simply need to acknowledge it. There's nothing wrong with saying, I'm so sorry, that didn't come out right. Let me try that again. Being human and authentic. We don't have to be perfect as providers. We have to be real and thoughtful and responsive. All right, so for the last few minutes, I will shift to communicating directly with children and adolescents. And as you know, over the course of time, we went from 90% of physicians not wanting to disclose, for example, a cancer diagnosis, to 98% of oncologists believing that disclosure is an ethical imperative. And we always have this tension, especially among children and adolescents, and we heard a little bit about it, families who are worried, very strongly worried about this disclosure. Well, what do adolescents and young adults think about end-of-life decisions? And this was a study in which AYA survivors were asked about certain hypothetical terminal cancer scenarios, as well as otherwise healthy adolescents and young adults. And they wanted to hear that non-treatment would be okay a majority of the time, and this is those who had gone through the cancer experience much more likely than those who are otherwise well. They wanted to hear that symptom management, aggressive, which is a word I don't ever use, this was used in the study, but intensive symptom management was okay. Adolescent survivors wanted to hear that more than otherwise healthy children. The patient has a right to be informed, 96% compared to 90%, and you would want to know yourself. When should we talk about death? So 38% of adolescents say from the very beginning. Only half with end-stage cancer actually reported that they had end-of-life discussions. What's important? 100% being told the truth, 100% being physically comfortable, free from pain, 100% being at peace spiritually, 94% understanding treatment choices, 88% being able to complete an advance directive. And where do you want to die? 64%, if given the choice, would choose to die at home, with 12% only in hearing about hospice in the U.S. What about amongst AYAs, with 52% of whom have advanced cancer? Is it helpful to discuss? Yes, it's stressful to discuss, but is it helpful to discuss? Who will make my medical decisions? What kind of medical treatment I want and do not want? How comfortable I will be? How I would like to be treated? What I want my friends and family to know? My spiritual wishes, and how I want to be remembered. It's still stressful for almost half of these kids, but it still means that they want to know. All right, this is some of Abby's data about the words of bereaved parents. I am grateful we never talked to him about it. Another parent, my only regret is that I did not talk to her about it. I protected him until he turned 18, you know. I tried to shield him so I didn't tell him everything. But when he turned 18, he did the same to me, and I felt shut out. I couldn't protect him. It makes it harder now. I know in your culture, you tell the patient, but that's not true in our culture. I think you should ask parents first. If you had asked us, we would have said no, don't talk to her. But that you insisted helped her find peace. She told us she was going to a place where there would be no pain and she would be happy. She got to live the way she wanted, and then she died the way she wanted. For your help in getting her there, we are forever grateful. It's this push-pull, right? We find ourselves in quite a difficult situation. And what about the words of the adolescent patient? Excuse me. I don't know why it's gray. I'm grateful we never talked about it to him. My only regret is that I did not... Oh, the same one. Sorry. Then another study from Chris and colleagues about being a good parent, and our parents' values are to strongly advocate for my child, to focus on my child's health, to making informed medical decisions for my child. And so we have an innate sort of instinct as a parent, aside from making sure my child feels loved, to sort of strongly advocate for them and strongly protect them. And then the words of adolescent patients. I hate it when they come in and talk to my parents and not me. This is my body, my life. Talk to my face. Sure, it's scary. No one wants to hear the bad news, but it's so much worse to feel like you don't know. It's hard when they gave you like false expectations and say it will be fine, and then you still have to go on, or it doesn't happen. It feels like they're lying then. It's better just to tell it the way it is. They keep telling me I'm not going to die, but it's still always on my mind. I have questions about things I want and things I want to do. I feel like I can't talk to my parents about it because it upsets them more. This is already so hard for them. I don't want to make it harder. So, as you can see here, in another study, mostly from Pam Hines' work, adolescents make decisions at end of life. The primary reason is because of their relationship with others. That's sort of the third of the pie. And if we summarize things, including the AYA with time may actually decrease parent distress, and joint advanced care planning may decrease anxiety, decrease depression, increase quality of life, increase activation and advocacy. The pros of including the adolescent voice, patients already know. Not telling them may heighten their fear. Patients want to know at the same time as parents. Over a quarter of parents later regret not talking with the child, and parent distress goes down. But then the cons are that patients may want filtered information. It may undermine the parent trust and therapeutic alliance, and actually 3/4 of parents who did not tell believed they had done the right thing in retrospect. And this may matter in bereavement. I think in the end, the short-term consequences of truth-telling is that it makes us feel it's difficult to do. We may feel less compassionate. We may worry about negative affect and being confronted by anger or anxiety or sadness. But in the long term, we gain trust, understanding, confidence, less distress, more hope, and decisions are aligned with goals and values. So let's shift very briefly to successful strategies to include the child and adolescent in communication. First of all, there are tremendous resources out there, and what we use more than anything is Voicing My Choices, which was created by Lori Weiner and her colleagues, and it's a booklet that you don't use all at once, but a little bit at a time. Usually we offer it to families to do with their adolescents, or the child life specialist does it with the adolescent and takes it one piece at a time to go through that booklet. And there are all kinds of online resources about communication strategies. And some simple strategies are what we would use in our normal conversations, like ask, tell, and then ask. And I'll just skip to, in light of the time, the idea of using the spikes model, which is setting the stage. Perception, so this is where you ask. We have some difficult stuff to discuss about your cancer. How much do you want to know? Are there things you would rather I talk about to your parents first? So you clarify, because every family is different, cultures are different, and adolescents have differences of opinion on what they want to know. Can you tell me what you have heard about the status of your disease? What have you been told about the reason we got the CT scan? So you're eliciting information. More elicitation through invitation. Your family has been through a lot. Could you please share with me how you would prefer to receive information? How should we talk to your child about what is happening? What do you think your child is most worried about? I'm afraid we have some difficult news to discuss. Is it okay to do so now? We have some stuff to discuss about the results of your MRI. How much do you want to know? So all this ask first. And then, of course, with permission, you tell, with a warning shot, with simple, non-technical terms. And then once you tell, you ask again. Was I clear? Does this make sense? Ask, tell, ask. And of course, always responding to emotion through naming it, through being silent, through exploring it more. And for sure, you need to summarize and then present a strategy. So in a sense, aside from the tools, and of course I didn't mention child life, and for younger children to allow them to express themselves and to explore their willingness to express themselves, the same basic concepts that we use for older people we would use for children as well. Ask, tell, ask. Simple terms, ask permission. So I was going to end in closing with just telling you about a patient that we consulted on. Her name was Taylor. She had a brain tumor, and she was an adolescent. And her team was so frustrated because they just couldn't, and she was very advanced in her illness, and they were so worried, and they wanted to protect her from care in the ICU, but she would not have a conversation about advanced care planning and about resuscitation status. And so we offered them one simple tool. Just ask her, Taylor, what's most important to you? Taylor, what do you want? And so through that open-ended question, Taylor wrote down a long list of what she wanted. And I'll read you just a few of the things that she cites. Her first thing, Taylor does not want to be on a ventilator, even though they had trouble talking to people about it. Taylor wants an ambulance to the hospital and home with sirens on. Taylor doesn't want to be afraid. Taylor doesn't want to be in pain. Taylor wants a shower every day. She wants dignity. Taylor wants to wear her fashions and makeup and her own clothes, and she wants diet soda, Coronas, and tea. Taylor still has hopes. Taylor wants to walk by Christmas independently. Taylor wants pink everything. Taylor wants to go to New York and shop and see a musical show, Chicago or Lion King. Think of that developmentally, Chicago or Lion King. Taylor wants to choose her own religion. Taylor doesn't want a tumor anymore. Taylor doesn't want snow. Taylor wants whatever Taylor wants. Taylor wants neat, trimmed, dark purple, brown, or pink hair. Taylor wants a cure, even an experimental treatment. Taylor wants a bigger room with a fireplace and a jacuzzi and a hot tub outside. Taylor doesn't want the doctors to start her heart again if it stops, and Taylor wants to believe in God. Taylor wants locks of love to take her hair if they need it. And Taylor wants Mom to keep reminding her about her list and her goals and her victories. Thank you.